All right, it's 8 a.m. and we are ready to get started with ocular pathology rounds. My name is Megan Klymans. I am one of the Coplow pathologists, and I'll start with our first two cases. Actually make that full screen. Okay. Dang it. Remain technologically impaired. All right. First case. Our first case is a 2-year-old neutered male Shetland sheepdog. The history for this patient is that this patient was non-visual with a mild buphthalmia versus exophthalmia. So the eye was kind of protruding. Possible mildly reduced retropulsion, some squinting, some swelling of the periocular area, some mild corneal edema, and some neovascularization of the cornea. 1 to 2 plus flare in the anterior chamber with an immobile 3 mm pupil, and they couldn't really see much behind that. So we have our gross exam up on the screen now. Maybe if this would go away, there we go. So we have our cornea at the top, and this is our hemisected globe with the optic nerve at the bottom. And you can see here in the ventromedial sclera, you'll have to take my word for it that this is ventromedial, and kind of here up at the limbus. So we have the cornea ending here and going into the limbal sclera here. So limbus is like right here, maybe like just posterior to that. There's this area where the sclera kind of becomes indistinct. So the sclera is this sort of bright white, dense collagenous structure, and it kind of goes away a little bit focally here, and is replaced with this different looking kind of tannish tissue. So that's of interest. You can kind of see maybe a plume of exudate tracking in that direction, but that may be kind of a stretch, and maybe you'll have to put your imaginoscope on. But in general, we also have some exudate, mostly surrounding the lens, but basically filling the globe, sort of plastered against the back of the globe here as well. A big cataract in the middle. You can actually see that tiny pupil here, which is kind of cool, full of that exudate. You can see why they wouldn't have been able to see past that. And a little bit of a nubbin of retina here, which implies probably some degree of detachment and probably tear. Um, that is our gross view. Let's take a look at the histology. That is our gonio slice. All right. So here's our cornea now on our left, looking at the histology. And we can see all of this purple surrounding the lens, a very wrinkled lens capsule, and very abnormal looking. We'll take a closer look at this end of the lens in a hot second. But looking over here at that area that looked a little abnormal near the limbal sclera, it's mostly replaced by this purplish tissue, and we'll take a closer look at that too. Lots of purple, too many cells. Here's our little nubbin of detached and torn retina, sort of curled on itself back there. An abinified retina. And that's kind of our little tour. So let's start by dropping in, I think, over here first. And it's difficult to tell what exactly is going on here, but at least partially the limbal sclera here is kind of replaced by a looser sort of fibrovascular tissue that is infiltrated by large numbers of inflammatory cells. So we have lots of neutrophils, we have a good number of macrophages, we have probably some lymphocytes and plasma cells, kind of lots of the friends are here. So this may have been an area of scleral compromise that kind of got filled in with something. And it's at least really severely inflamed in this area. We zoom back over to the other side, which is interesting that it is on the other side, but we have an area of lens capsule discontinuity. And it can sometimes be difficult to be sure whether it's an artifactual versus a true in vivo lens capsule rupture, but the lens end kind of curls on itself a little bit, so I'm prepared to call this a real lens capsule rupture. That and the large numbers of inflammatory cells that are admixing in the lens fibers and kind of extending deep between the existing lens fibers. If I were smart, I would have found the other thing of interest in the lens in advance, but I did not. Let's see. There were bacteria in this lens, and if it takes me forever to find it, I'll just give up and move on to the next thing. Mm. Yeah, maybe we'll just move on to the next thing for now. Should have put a dot for that. But there were bacteria embedded in that lens too, which is interesting given the rest of the findings. All of this exudate in the vitreal space is mostly neutrophils, but in particular, there's this little structure of interest. If we look closer at that guy, that guy's not supposed to be there. So surrounded by some neutrophils, we have a little tiny foreign body. And if we look even closer at it, so pretty. It's got these kind of polygonal, rigidly defined spaces, which sometimes have kind of indistinct cellular stuff in them, maybe kind of dead cells at this stage. And these are kind of poorly staining, kind of refractile, thick walls. Oh, it's already in. All right. And we're going to find our little lens. And it is birefringent as well and kind of pretty, although the camera makes it even weirder.
Psychedelic.
Yeah, it is psychedelic. Okay, we'll pull that out now. It should be out. All right. So this is most likely a plant foreign body. So we have a really severe endophthalmitis, a plant foreign body in the vitreous, a lens capsule rupture, and a possible limbal rupture in the ventromedial limbus. We also ended up having bacteria in the lens, which I'm not going to show you, I guess, unless I could find it really quickly, which I don't think I can. So we're going to come back over here and land on our foreign body again while we talk some more about stuff. So this is a contaminated penetrating trauma, and we would assume that it is associated with a plant to some extent. This could be a migrating plant foreign body, or it could have been kind of carried in here by a contaminated penetrating trauma. The location of the penetration site, if you can find it, is useful for making some interpretations of these cases. Generally speaking, if it's more kind of like posterior and ventral, you could consider the oral cavity as a site of origin for a penetrating trauma. And if it's more dorsal, it could be, and especially more kind of anterior, it could be more coming from outside the body. So it's ventromedial and kind of limbal, and it's difficult to say exactly where the penetration may have come from. And the bacteria in the lens is very interesting, but I would assume that the lens was just involved in a contaminated penetrating trauma. We do have a condition referred to as septic implantation syndrome, but that tends to have a different sort of pattern to it. So usually it is a penetrating trauma that happens sort of earlier on before enucleation, embeds bacteria into the lens. That bacteria kind of brews long term and then eventually erupts with a very phagocentric inflammation. This is kind of more of a hot penetrating trauma that didn't have any period of quiescence. So I would just call this a contaminated penetrating trauma. All right. That's kind of all I wanted to talk about with this case. We could actually, before we move on, we could show you the retina a little closer. Oh, and there's a question. Go ahead.
Oh, I was just wondering, when you said that you knew that the lens had ruptured, like antemortem, because it was curling, why was that? What was that?
Yeah, so the question was how we can tell an in vivo lens capsule rupture and referencing the curly lens capsule. So generally speaking, if it's a break in the lens capsule that happened post fixation, you'll tend to see just a sharply discontinuous like end of lens capsule. And it won't really kind of curl back on itself. The way that it kind of like springs back like that kind of implies like it was probably not fixed at the time, at least. So it's sort of at least a corroborative piece of evidence suggesting that it was an in vivo rupture. The other things you could use, like I said, if you see those inflammatory cells that are really kind of extending into the lens, kind of between cracks in the lens fibers, you don't usually get like too much of an artifactual admixing of inflammatory cells. So that also is a piece of evidence that suggests it was a true in vivo rupture. Great question.
Getting the lobes intact, right? And they're normal, and then you have to section them.
Yes.
Not only do they get sectioned by our blades that are hopefully really sharp,
Yeah.
they go through the structures appropriately, and then they go on to, after they're bedded in paraffin, they go onto a microtome. Every one of those things can cause an artifact.
Yes.
But because it's already formal and fixed or in the process of being fixed, they don't tend to move. So beforehand, they tend to pull back and curl up.
Yes.
Formal and fixed, they usually just stays. Good.
Yeah. Just further clarifying how things kind of tend to stay in place when it's already formalin fixed, and if the artifact is induced by like a microtome blade or our blades when we're grossing. Also, hopefully it's not annoying to repeat. I never know when it's a good idea to repeat and not to repeat. All right. Any other questions or comments? This was just a closer view of our nubbined, detached and torn retina. And to our diagnosis. And there we go. Here it is. Sort of the main diagnosis for this case. And if there aren't any other questions, we'll do the next case. This one is one of those cases where it's really cool for the pathologist, but sometimes that doesn't mean good things. So this is a 5-year-old neutered male cardigan Welsh corgi. So this guy, I'll withhold some of the pieces of history, but we'll discuss some of the other ones. So previous history of lupus, recently developed nasal planum depigmentation. So that's kind of interest because this patient may be on immunosuppressive or immunomodulatory therapies. Let's see. So actually, I think I may withhold like most of this history. Yeah, maybe I'll withhold most of this history. Bad eye. And given that we have a history of nasal planum depigmentation, they may have been concerned with a certain condition, if you can think of what that would be, while I kind of go into some more detail here. So this is our hemisected view of this globe. This globe was a little bit enlarged. We can see that the inside of the globe is full of hemorrhage and pus, this sort of white tan exudate, and maybe some high protein gel. And probably the retina is detached. You can kind of make out a little bit of a fan of tissue here, but it's actually kind of hard to make out what the retina is doing, and certainly hard to see the optic nerve head. And we have a cataract up here as well, briefly. So if you guys were thinking about what might cause nasal depigmentation and what they might have been worried about, they may have been worried about uveo-dermatologic syndrome, also known as VKH-like disease in dogs. But this is absolutely not a expected gross presentation of VKH or UDS. Basically, with that, you would expect to see a uveo-centric inflammation, so the uvea would typically be quite thickened. Usually, it's more of a pan-uveitis, although it may not always be. And usually that is a bilateral condition in the globes. We may or may not see the dermatologic manifestations with UDS, but we typically see bilateral presentations. In this case, the uvea may be involved, but it's generally quite thin, and most of what we're seeing is intraocular exudate. So this is not a gross presentation that we expect with UDS. All right. Oh, I'm going to try and standardize the way the cornea is facing. Here we go. I flipped it around eventually. All right. So here's the cornea up on our left, more or less, kind of like left up. We can see some cute features as we walk around the globe already. So this iris leaflet is fused to the anterior surface of the lens, mostly at the pupillary margin. And we can see that it's kind of a thinned and anteriorly bowed iris leaflet. And this is the histologic finding that implies iris bombé, that condition that can cause 360-degree pupillary block, and then the iris bows forward and looks like a donut from the front. We're not going to walk around the edges because what's happening is mostly in the intraocular chamber. Here we go. There's so much exudate in here. Lots of blood, lots of exudate, lots of purple stuff. Just kind of walk across and take a look. And from low magnification, we can actually also see how kind of these areas of purple are sort of more linear and look like they actually have layers to them. This is most likely retina, but it's a very unhealthy and unhappy looking retina. So pretty much that's what we're seeing, really severe endophthalmitis in this case. And we'll just zoom in on this. I did find an area in advance this time. So the way that these inflammatory cells kind of clump in the vitreous is very interesting. If you find kind of clumps in the vitreal space, whether sort of following a linear pathway or sort of forming little clusters like this, you generally want to zoom in and see what might be at the center of that. These cells may be interested in something. Most of these cells are actually variably degenerate neutrophils. And if we kind of keep following these clumps, we should, hang on, right for it. Oh, come on. I know there's the one I wanted around here. I blame the fact that it's reversed from where I usually put it. If I look through the head really quick, I'll find it for you, I promise. Almost positive it was over here. Please. Okay. I'm going to flip the slide around again. My spatial awareness is not great at the best of times.
I'm the same way.
It should have been the same area. Okay. This is again why I should have just put a dot. Paralysis of the marking pen hand. Okay, I can't find it. We'll go back and find it later, perhaps, and we'll put the specials on to show you guys first. The things that are of interest to these inflammatory cells are actually not very easily found by H&E, but there was at least one area that was. We'll go back. Let's pop on the gram stain.
Make sure I gotta focus on the screen.
Oh, right, gotta focus on the screen. Sorry about that. So we can see from low magnification these areas at the center of those clusters of inflammatory cells that are a little bit kind of purplish. And if we zoom in on that, keep zooming in. There are some friends here. Not very friendly friends, but friends. That's as close as we can go. Wait, sorry, is it? Mouse scroll. Oh, mouse scroll. Thank you. That's probably too close. All right, so we have these chains of rods to filamentous bacteria. These bacteria are weakly gram positive, so some of them aren't really picking up gram, but a lot of them kind of are, so I would characterize that as a weakly gram positive. And they're forming these kind of clusters of filaments here in the mostly vitreal space of this animal. We did throw a GMS on this just for fun. Oh, yes, now we're gonna have to scroll back. Not that far. Yeah, okay, right there is good. And you can see that these bacteria are also argyrophilic, picking up the silver, as bacteria do. And you can see these nice filaments really well with the silver. So these are filamentous bacteria that are weakly gram positive. We could have thrown an acid fast stain on this, and we probably would have got either a negative or a weakly positive result with that. But we did not do that. And maybe I won't go back and keep trying to find the H&E. I should have just marked it. They were hard to find on H&E, but it was possible to find them there. And the extra history that I withheld from you for this case is that this patient has been a dermatology patient since 2022 for otitis and allergic dermatitis, acute onset of crusted ulcerated lesions in July of 2023, starting in the axilla, then spreading to the dorsum and lateral thighs. So some pretty extensive skin disease. Let's see. Long story short, they did a histopath on the skin, which showed gram negative, they said, chains of bacilli and GMS positive branching organisms with a pyogranulomatous dermatitis / paniculitis, and microbial testing revealed the presence of nocardia. So this patient has nocardia in the skin, and let's see. That's kind of the main thing I wanted to tell you. Also, they did some fungal testing, which was negative. So we have a filamentous organism both in the skin, confirmed as nocardia, and a organism that at least is not inconsistent with nocardia inside the eye. Typically, these types of organisms are saprophytes, and they're kind of in the environment, and more commonly create infections by kind of penetrating trauma or like penetrations to inoculate it into place. I would say that a sepsis associated with these organisms is uncommon. but possible. And in this case, sepsis may have been what happened. And you kind of wonder if this patient was immunosuppressed or something like that that may have contributed to why this could have happened. Generally speaking, Gesundheit. Generally speaking, if you see microorganisms inside the eye, the pathways of infection to consider are hematogenous spread, inoculation via penetrating trauma, or just sort of local spread. So keep in mind that the oral cavity, the nasal cavity, all that sort of stuff is kind of close together and close to the orbit. So stuff can kind of spread from local areas. In this case, kind of favor hematogenous spread, even though it's kind of a weird organism to do that, given the patient's history. And definitely an unusual case that we don't get too often. If there aren't any questions or comments, I will move.
My name is Kelsey Brown. I'm one of the other Coplow pathologists, and I'll be going through the next two cases. Making sure I grab the right one first. There we go. All right, so our first case is from a 3-year-old male castrated domestic short-haired cat. The submitting clinician was kind enough to share a few clinical photos with us that are really quite lovely. So that's going to be on the left here. Actually, pull up the history. So the clinical history that we received is that this side, the right eye, is open, but they're unable to appreciate the globe itself, as we can see here. They described mild serous discharge dripping at the medial canthus, which is pretty exuberant in this photo. They're unable to retropose the globe, and palpation around the orbit was non-painful and reveals extension of a mass beyond the orbital rim. They described moderate conjunctival swelling and then hyperemia with a pink hemorrhagic proliferative tissue axially, which perhaps that's kind of right here, covering what should be axial cornea. And then there's dense yellow to white tissue nasally. So perhaps right here, just this kind of rim of tissue, the nasal aspect. And there's a mass effect in the orbit. They did do CT, which revealed a large mass in the front part of the right globe, appearing to arise from the conjunctiva with no bony involvement. And this has been going on for about 3 to 4 weeks. Okay. And then on the right of this slide, this is going to be our gross hemisection. And we can kind of corroborate what they were able to describe clinically. So we do have this rather large mass effect. It seems to be involving the cornea. So we described the cornea as 1.3 centimeters thick, which is a little thicker than we'd like to see in a cat's cornea. It also seems to be involving the bulbar conj. It's a little hard to make out the demarcation between the cornea and the conjunctiva. For orientation, we did also leave our eyelids on, so we can see a little bit of the haired skin of the eyelid right here, and they seem to be maybe relatively unaffected, as they are in the clinical photo as well. And then the rest of the globe is relatively unremarkable grossly. There is a little bit of artifact just from our hemisection. I imagine this was horrible to try to bisect. So we just chunked out the lens a little bit. There's maybe some extra tissue that might actually be the lens that got removed right there. So kind of ignore the somewhat dirty edges of our hemisection. Yeah, right. All right, so we can move to the histology. All right. It's going to be, I'm going to actually start at the posterior aspect just to help us orient, because the anterior aspect of this globe is a little bit of a mess. We don't quite have all of the posterior aspect of our globes. We kind of pick it up again here. So we have choroid, retina, sclera. There was an iatrogenic laceration with removal of this globe, which I think is very understandable with how distorted the globe is. I do also think that maybe we lost a little bit of the tissue just when this was getting sectioned and put onto the slide. But most of the globe in the posterior aspect is unremarkable, including our lens here. So I'm not going to really revisit this section of the globe. We'll kind of stick around the anterior face. So moving to the axial portion of our anterior segment, we have a little bit of remaining cornea, if you will believe me. So here's Descemet's membrane. There's a very thin, kind of crisp eosinophilic band. Moving forward, we have our corneal stroma, and then everything else becomes very distorted. So we have a cellular infiltrate kind of moving over here. We can see it's just a lot more kind of purple blue. So this corresponds to cells. A lot of areas we kind of lose that purple blue staining. So these are actually just large areas of necrosis. And then we kind of pick up those cells again. Speaking of artifacts, here's another one. This is just an area where the tissue got chunked out when it was being processed. So we can ignore that. So the cellular infiltrate mostly affects our cornea. There's areas, so here's our sclera here, kind of our equatorial or limbal sclera, where those cells are also infiltrating. If we move kind of more forward here, I'll kind of just move over to our normal-ish eyelid. So we can see the haired skin of the eyelid. It continues to become conjunctiva, so this is going to be our palpebral conge. And then it wraps around to become the bulbar conge here. And we can see that there's also infiltration of that bulbar conge by this cellular process. And while I'm on low power, I'll also point out, going back to our cornea, so we can kind of make out where there's stroma. At some point, maybe like right here, we should be seeing corneal epithelium. But as we continue, really there's no epithelium to speak of. And we really just have transition into our bulbar conjunctiva. So we should have a very broad symblepharon. We can move over here. Here's a little break in the bulbar conge where we have fibrin kind of exuding out, and then we pick up the bulbar conjunctiva again. So just pretty intense symblepharon, which corresponds to that pink tissue that they were seeing clinically likely. All right, let me find a more viable area to actually look at here. Let's go even closer. Ooh, maybe. There we go. All right. And our cellular infiltrate is a rather monomorphic population of round cells. So this is a neoplasm. Feel comfortable calling them round cells, one, because most of them are indeed round, and they have pretty well demarcated borders, and they're just arranged in these sheets. And these are all things that we tend to see with round cell neoplasms. We imagine that if we could take a pair of tweezers and kind of pluck one out, it probably wouldn't disrupt the remaining cells around it. Yes. And as we move around, some other features of this neoplasm that are kind of helpful in deciding what exactly this is that it has a rather high nuclear to cytoplasm ratio. So if we kind of pick one out here, so this guy here, he has a rather large nucleus and really just a small sliver of cytoplasm. His neighbors are very similar. Has pretty finely stippled chromatin, 1 to 2 pretty prominent nucleoli. So we can kind of make one out right there. And I feel like this particular neoplasm is rather necrotic. It's a little bit hard to point out very specific mitotic figures, but there are some mitotically active areas. So I believe we got 17 mitoses per 10 high-powered fields. So it's making moves. I'm gonna move around just to the edge here. Then one other feature of this neoplasm. Maybe. This is why I put a dot down. There we go. These are some areas where there are pretty impressive eosinophilic infiltrates. So all of these round cells with the brightly eosinophilic cytoplasm, it's a little hard to make out their individual granules. And they have a bilobe nucleus. These are eosinophils, which could be somewhat suggestive for what neoplasm this could be. Oh, goodness. And then those are kind of the main features. There are areas where these neoplastic cells kind of spill into the anterior chamber here. And then we also have this very focal eosinophilic infiltrate kind of on the anterior face of the iris and moving into the stroma, which is just kind of a fun little finding. But otherwise, the remainder of this globe is relatively unremarkable. Not that this cat needs anything else in its globe. So we did, just because of the eosinophils and this being a round cell neoplasm, we did perform a toluidine blue stain, which is a metachromatic stain that we use to identify mast cells. It was negative, so likely this is not a mast cell tumor. So we had originally put this out as a corneal conjunctival round cell neoplasia, and our top differential for this was lymphoma. It sounds like at the referring institute, they did do a conjunctival biopsy initially, and immunohistochemistry was performed on that. And that showed that the immunophenotype of these cells is T cells. So.
Wait, done that afterwards, or?
It sounds like it was done kind of concurrently or before, perhaps, like shortly before the enucleation was performed. I don't quite know the timeline, but after the fact, the clinician contacted us and told us that this had been immunophenotyped. So we were able
It would have
to.
helped too. They knew and kind of knew as the chemistry.
It sounds like just from the history, they give us a really nice history. It sounds like maybe this was happening like alongside,
time.
yeah, our biopsy. So we were able to give a more specific diagnosis in the endocorneal conjunctival T-cell lymphoma, which has some parallels to Dr. Kleinman's case from 2 weeks ago at our last rounds, but good repetition and also a very interesting presentation of it.
Did they comment on the systemic status of this patient?
Yes, they did. And I even highlighted it, I think. Yes, that's systemically doing well.
Okay.
So.
Yeah, you never know what to do with cases like that. And now the main questions for clinicians when we get a lymphoma around the eye or in the eye is, and for everyone, is this part of a systemic lymphoma that spread to the eye, or could this be a localized solitary tumor arising there that becomes that might become systemic later? We have a large number of cases where, kind of like this one, we don't get history of systemic disease with lymphoma. That doesn't mean it's not already systemically spread, right? But you would expect that, a case like that would be. We do have a large number of cases, significant number of cases where we call presumed solitary ocular lymphomas, which are lymphomas where we make the diagnosis when there is an intraocular lymphoma without a history of a systemic lymphoma at the time of evaluation. Those cats and dogs also, they tend to do better prognostically wise, mainly in terms of survival time. But that study mainly focused on intraocular lymphoma, so we don't know if the same thing would apply to periocular conjunctival lymphomas or ocular surface lymphomas like this, the present case. Okay, it's very good.
That's nice.
I was just, when you said that the eosinophil infiltration that was suggestive of a cancer type,
Yes, thank you for asking that. That was somewhere in my head to mention. So when we see
Can you repeat
round
the
cell,
question?
oh yeah. So the question was, what's the significance of the eosinophils? I think I laid some significance on them and never followed up on that. So thank you. So when we see a round cell neoplasm with eosinophils, I think a lot of times kind of one of the first things we jump to is mast cell tumor. That's a really common one that can recruit eosinophils. We can also see eosinophils with certain lymphomas. T-cell lymphoma often does like to recruit eosinophils as well. So it kind of just helps corroborate what the final diagnosis was. Yeah.
Just in general terms, eosinophils inside the eye are very rare. For some reason, we don't see them in the uvea. So I guess for us, it just stands out every time. Oh, there's an eosinophil in the iris or in the choroid, Question here, did they do cytology, corneal scrape? It would have been, I bet it would have been diagnostic. And for Bazel's estimate.
Let's see.
I agree, that would have helped.
They
But then we wouldn't get the
did
eye, so.
that. And that's the priority, right? So they did do, if I'm recalling, they did do cytology. They attached the cytology report. If I'm remembering, they didn't put the cytology results on this piece of paper. But if I recall, I think it was low cellularity, perhaps.
Okay.
Like, I don't think it was entirely diagnostic, or perhaps there were some suspicious cells, but that's just going off my memory, so no one quote me on that.
Just to be clear, I was joking about not receiving the eye. This being broadcast to the world. It'll probably be sent to us at least a biopsy for phenotyping, things like that, if they think about it.
I also wonder if they had scraped it. It was that like really broad symblepharon,
Right.
and those cells were a little deeper. So I could see why it would not be the most diagnostic sample.
Mhm. That's a good point.
But
Cool case.
all right, cool. If there's no other questions, I can move on to my next one. I have a bit of a theme of anterior segment disease in cats. And young cats too. So my next one is a globe from a 1-year-old female spayed domestic short hair. Right. It's a little bit less of a history for this one. So this is the right eye. Clinically, they describe ophthalmos, large corneal perforation, suspected orbital cellulitis. So here is our hemisected globe. And the person who trimmed this globe and grossed it out had a very descriptive way of describing this globe, which I enjoyed. So we indeed called it ophthalmic. We said it was due to the cornea. There's this very large kind of anterior bulging of the cornea. We described a bulging, in all caps, tan ulcerated perf. We said the corneal bulge almost looks like a globe on top of a globe. It's like, I enjoyed our notes for this one. We also described a broad anterior synechia. So let's see, here's maybe the base of the iris right here. And if we follow that leaflet where the pigment is, we can see it's broadly adhered to the posterior aspect of the cornea. And then this kind of irregular tissue here. So I imagine this was the perforation that we were describing, where there's really not normal cornea. The anterior chamber, or I guess we don't have anterior chamber, so our posterior chamber is filled with this kind of tan fibrinous material that's also adhered to the anterior lens. And then if we move back to the posterior segment of the globe, it's relatively unremarkable. We can see our optic nerve and little optic nerve head right there. Speaking of artifacts, as I was looking at this morning, this one has a couple of unfortunate artifacts I'll just point out now, and hopefully we can ignore them. So there are a couple of scratches in this cover slip. So this here is not a foreign body. This is just a very large scratch. Same right here. And then we have a few folds in the tissue as well. So all of these very dark purple kind of linear lines here, those are all just folds. There's a pretty large one right there. Here's another scratch. So I'll try to avoid these if I can, but try to ignore them from your mind. All right. So I will start right here. So here's our bulbar conjunctiva. We have a small little segment of it. We're at our limbal sclera here, and then moving into the cornea up at the top of the slide. So right at the fornix here, there is a fusion between the conjunctival epithelium and the corneal epithelium. So we can see this kind of like linear area of epithelium. So this is a peripheral symblepharon compared to the very broad one from the other case. As we move over into the cornea, we have a little bit of normal-ish cornea. It is also, there's a lot of reactive changes. So there are these large vessels within the corneal stroma. So it's pretty heavily vascularized. And there's a lot of blue stippling. So there's a cellular infiltrate as well in this corneal stroma. As we move more axially to the central cornea, we get dropout of that normal corneal stroma. Instead is replaced by this pretty cellular tissue that's a little bit hard to make out the finer details at this power. So we'll go a little higher to look at that. Moving back and just kind of fanning back over, looking at our iris leaflet, it's rather distorted. We can kind of see there's a little bit of pigment iris epithelium that we can follow to help us orient. But it is, as we saw grossly, broadly adhered to the posterior cornea. And as we move into this defect in the corneal stroma, we can see that it's kind of following it and adhering to this abnormal tissue. And we'll kind of see a similar thing on this side. So a little bit of normal peripheral cornea. We have this broad anterior synechia, and then we have this kind of loss of corneal stroma, replacement of tissue, and then just broad adhesion of the iris to this tissue. And then I'll just move back to the posterior segment, which, similar to the other cases, relatively unremarkable. So ciliary body into our retina and choroid. Our optic nerve head wasn't very well sampled in this particular section. And then our lens. So I'll similarly stay away from the posterior segment now, since there isn't much going on there. All right. Just showing that symblepharon a little more closely. We're a fusion of the epithelium of the bulbar conjunctiva and cornea. And then moving into our remaining corneal stroma, then we have that vascularization. Just looking a little more closely, that cellular infiltrate is a mixed inflammatory population. So we can see some little neutrophils. There's lymphocytes and plasma cells. And then we have our remaining desmase membrane. And as we move into this very large defect in the axial cornea, we can see a pretty sharp discontinuity in desmase membrane. And then as we kind of follow our cornea, or what should be our cornea. You can see we have loss of stroma and replacement with this very busy fibrous connective tissue. So it's rather loose. There are a lot of these plump spindle-shaped cells. And if I move to perhaps a somewhat less busy area, which might be in vain, we can also see these perpendicular small caliber vessels that are interspersed with this fibrous connective tissue. So this is granulation tissue that has replaced our corneal stroma pretty extensively. And if we move kind of into the globe, we can see a little bit of that pigment iris epithelium. So here is our iris leaflet that's kind of blending with the granulation tissue. And going back to kind of the edge of like the section where we have the junction between normal cornea and corneal loss, there is a very modest attempt to re-epithelialize this defect. So here's a little bit of corneal epithelium that is spread from the adjacent cornea over this granulation tissue. So it's giving it the old college try. And just kind of going over to this edge here, showing it's a similar process on this side. So a lot more of this granulation tissue. There's an area where we have more desiccated tissue and some fibrin and neutrophils on top, almost forming this crust on top of the eye. Looking at our iris a little more closely too. So our adhered iris is extremely edematous. So the stroma is expanded by clear space, this kind of proteinaceous material. So this is all edema. And it's also rather heavily inflamed. So mostly lymphocytes and plasma cells. There's occasional neutrophils as well in here. And moving in and out. Just on this side, again, here's our desmase membrane. So this is again where we pick it up and then we can follow it over to our more normal-ish corneal stroma. All right, and I believe those are all the changes I have for this globe. So I will move over to our PowerPoint. So here are more for this. First, morphologic diagnosis is rather lengthy and verbose, but all in all, these changes are most consistent with feline early life eye disease. So the supportive changes are going to be a very large defect in the corneal stroma due to necrosis, causing perforation and iris prolapse. We have secondary granulation tissue formation because of that. And then there's also going to be this mixed inflammatory infiltrate within the corneal stroma. So feline early life eye disease refers to a loss of the corneal stroma due to necrosis, typically in the neonatal period of the cat. So then you get secondary prolapse of that uveal tissue, and you can have re-epithelialization of that iris tissue or granulation tissue on top, is what we saw here. Oftentimes, these cats also have peripheral symblepharon, which is maybe suggestive that there is a herpes virus at play here that's causing this corneal necrosis. There is a somewhat recent article that came out. I guess 2008 is no longer recent, but a recent-ish article showing that cats with this particular collection of lesions were not positive for feline herpes virus, but instead of feline calicivirus, suggesting that maybe other viral entities could also contribute to this particular entity. And I think that's all I have to say about this.
Dr. Lee was asking here,
Yeah.
if you know if the cat was comfortable, if his eye was comfortable.
That
What was it again?
1 year.
Yeah.
1 year, 6 months. Yeah. What's that?
It's a little hotter than usual, so I would wonder if the cat's uncomfortable.
Yeah. No, it was a pretty brief history. They just said ophthalmos, large corneal perforation, and suspected orbital cellulitis. But yeah, I agree. It's pretty heavily inflamed. So
Yeah, the reason Dr. Lee asks that is because that's not uncommon in the history of these cats. It looks horrible and it's very inflamed, but they can be very stable for a while. The idea is that it happens, as Dr. Brown was saying, when in the early or right after birth, or and then the eyelids are closed. So there's time for the prolapsed iris tissue to be re-epithelialized, and we don't get a lot of intraocular inflammation as we see in this case. It's mostly concentrated on the cornea. Great.
Cool. All right. I will pass the mic to Dr. Gillian Shaw. Alrighty. Oops. Oh, okay. Next up is a cat. This is a 1 year, 1 month old spayed female Burmese cat. The history that we got was, well, there's a lot here actually. So this cat has actually been diagnosed with FIP, the wet form, had abdominal distension with effusion. Let's see here, hyperglobulinemia that resolved, hypoalbuminemia that was resolved. I'm not sure if they actually treated this cat with the newfangled drug or not. But anyway, turns out that's actually irrelevant to the eye. What they did tell us about both eyes actually is that this cat has been diagnosed with anterior segment dysgenesis in both eyes with suspected congenital glaucoma of this eye, and then they enucleated this eye. So, grossly here, I wish I could get this. How do I make this go away? Oh, well, the cornea is up here. It's covered up a little bit. There we go. So what we are lacking in this globe is the anterior chamber. So similar to the case that Dr. Brown just showed, there's no anterior chamber. And what we have is this brown tissue that's diffusely lining the back of the cornea. So that's broad anterior synechia and anterior chamber collapse. We do have some strands of uveal tissue kind of crisscrossing what would be the posterior chamber. This is our detached retina. It's probably torn at least on this side as well. And what we're not really seeing very well here is the lens. And I'm trying to remember now if I saw any evidence of it histologically. So, and keep in mind, this cat has already been diagnosed with bilateral anterior segment dysgenesis. And there's a clinical photo of it, which I will show you after I share the histo. So, all right. So, do the low mag thing here. So, here is the optic nerve. Here's the retina. This is an extra slice of the globe. We can ignore that. But at the front or on the left here is the cornea. And once again, we're lacking that anterior chamber. What we can see is this layer of darkly pigmented material, which is the iris that's plastered up against the back of the cornea. On this side, we have a little bit more recognizable iris stroma. And then this is also iris. Here's actually some of the ciliary body plique. So the ciliary body's back there. So the anterior uvea of this globe is very distorted. And as we can say, at least in this section, there's no evidence of lens. So I'm gonna focus a bit here. Focusing is a good idea. So here's our corneal stroma. It's a little bit disorganized, a little bit busier than it should be, and it's got some blood vessels in it, so it is a vascularized cornea. We do have this iris tissue here that is broadly adhered to the back of the cornea. And that actually continues as a very thin line of uveal tissue. So once again, we have broad anterior synechia with anterior chamber collapse. And that carries on. This is, it was a big enough globe and it got a little bit wrinkled on the slide here. Here are ciliary body plique, and then here's the peripheral retina. So. So what we are lacking in this eye, that I'm not going to spend a whole lot of time trying to show you that we're lacking it, is Descemet's membrane. So it's very difficult to discern. A PAS stain would have helped to highlight the basement membrane, the Descemet's membrane, but I did not do it. But it was hard to pick up. One thing I wanted to point out is that here under the corneal epithelium, there's this dense layer of mineral, and then there's more sort of finely granular basophilic material in the anterior corneal stroma that's also mineral. So this is band keratopathy. In younger animals, it tends to be this sort of chunkier version of it. If I have time for the next case, I'll show you more of it in the next case.
And so that's more of like more common in a younger animal as opposed to an older animal where it's mostly a fine basophilic dusting just under the epithelium. So here is just a really convincing area where Descemet's membrane is absent, and we have this iridoid tissue that's sort of blending with the deep corneal stroma. What is mostly lacking in this eye is any kind of inflammation. So there's very little inflammation anywhere in this eye. And then as we go back, as I said, the retina was detached. It is lacking its full complement of layers. So we should be seeing more nuclear layers than we see here. What we are seeing, so here's the nerve fiber layer. This is the ganglion cell layer. There might be a few cells here and there. There might be one there. So this should be the internuclear layer. And then what we're lacking is the outer nuclear layer, which should be out here somewhere, and it's completely absent. So this is retinal atrophy, likely associated with prolonged retinal detachment. The optic nerve head is not well sampled. So that is the majority of the lesions. Those are the lesions in this globe. So we have very difficult to identify Descemet's membrane. We have some corneal stromal changes, including fibrosis and vascularization. And then we have broad anterior synechia, which means when the iris is adhered to the cornea, and anterior chamber collapse. So we're going to go back to our PowerPoint.
No signs of lens?
No signs of lens in that section. I did wonder, based on the gross photo, if there may have been lens in that tissue, but I didn't go deeper. Okay. So let's go back to our PowerPoint real quick. I was hoping to show both of these cases just as a so broad Descemet's membrane absence and broad anterior synechia causing anterior chamber collapse. So we have I have two differentials for this. One is Peters anomaly or anterior chamber cleavage syndrome. Oh, sorry, this was my main thought on this one, based on the clinical history. So this is a form of anterior segment dysgenesis where we just have some sort of abnormal development of the anterior segment. And then in this case, we also have corneal epithelial changes with conjunctivalization and band keratopathy, anterior stromal mineralization and stromal fibrosis and vascularization, and chronic glaucoma, which was presumed congenital. So here's a clinical photo of this cat. So we received this eye, which you can see is quite a bit larger than the other one. And remember, they said this cat has bilateral anterior segment dysgenesis already diagnosed clinically. And in this case, on the less affected eye, we have this white area of the cornea. That's also called a leucoma, which basically means a white spot. And you can also hopefully discern, if I can get my mouse to reappear, these strands of iridoid tissue that are kind of coming forward to that white corneal spot. So those are persistent pupillary membranes, and they're little tags of iris that come up and meet this spot in the cornea. So this is a less affected eye with Peters anomaly. And Peters anomaly specifically refers to an axial, meaning central, deep corneal stromal defect, and also defect in Descemet's membrane. And then typically the iris is incarcerated there. And that leads to this localized corneal stromal fibrosis, plus or minus vascularization, probably originated from the vessels, probably came from the iridoid tissue itself. But anyway, so in most cases of anterior segment dysgenesis in animals, especially if they come with a history of the other eye being normal, we assume that it's a unilateral disease and that the other eye is not necessarily at risk of developing any other problems. In this case, however, this cat already has problems in the other eye. One of the other things that can accompany this more central lesion, which we look at this and think like, okay, big deal, whatever. And it's true, although this white spot would cause problems with vision, they'd still be able to detect light and see movement and things like that out of that eye. However, they also often have malformation of the iridocorneal angle with decreased aqueous humor outflow and then eventually develop glaucoma. So then we would call that congenital or juvenile glaucoma. So hopefully this patient keeps her other eye there, and that she hopefully is recovered fully from her FIP. As I said, there were no signs of the FIP in this eye. So that's good news for the cat. So are there any questions? I'm going to move on to another case that has similar lesions. Okay, moving on real quick here for my last couple minutes. This is an eye from a 5-year-old French bulldog who is spayed female. She was from a rescue, so we probably don't have a whole lot of history. What we do have is that they say blindness and glaucoma and KCS of this eye, unknown duration. So I get the feeling, as I said, this was a rescue dog. So we don't necessarily know the history. Interestingly, they also say the other eye is also glaucomatous and has KCS. So when we got this globe and hemisected it, once again, the cornea is always at the top of the image. Just like the last image, there's no anterior chamber here. What we do have is dark tissue lining the entire back of the cornea. So that's the back of the iris that we're seeing. So there's anterior chamber collapse, broad anterior synechia here. We also have this thin band of tissue that is sort of extending from the ciliary body plique. And you can see the other plique in the back there. And then here's our little dinky retina. It was probably like a little tiny tornado that was attached up here somewhere and actually got torn when we hemisected it. So it's kind of folded back on itself. So we have a dinky little retina there.
Got a cool metallic sheen to it.
Yeah, it does.
Like a
Yeah.
beetle carapace or something.
Yeah. Yeah. Okay. So, let me show you the subgross. So similar to the last case, although it's facing a different direction, here's the corneal epithelium, here's the corneal stroma, and what we have here is, oh, I know what I did wrong. Sorry. Let's do that. I knew it didn't feel right. All right. So there's our cornea. And we have iris tissue that comes up and is plastered back against the back of the cornea. So we have anterior chamber collapse. You can see where it kind of reflects backwards and meets this band of tissue. And then there is our little dinky stalk of retina right there. So now there we go. Okay. So much like the last case, when I mentioned that young animals often have this really chunky form of corneal stromal mineralization, this eye has that as well. The corneal epithelium is also hyperplastic. And it's also pigmented. There's some melanin pigment in some of these cells, and it's also slightly keratinized. So this is just an indication of probably exposure due to ophthalmos. And I'm trying to find the mineral that I promised you I would show you. There we go. So these are big accumulations of mineral. So that's very common in young animals. However, remember this dog was 5 years old. I get the feeling this eye has been abnormal since this dog was a puppy. Anyway, so not hard to find the iris here that's plastered up against the back of the cornea. Descemet's membrane was present here in multiple segments, discontinuous segments across the eye. As we move backward into the eye, we start to pick up some of this brightly eosinophilic blobular stuff. And that's actually lens. And here's a little bit more lens. So there was lens in this eye that was ruptured or congenitally abnormal. And so we have a resorbed cataract essentially, and there's a little bit more of that here. Right up in there. There's a little squiggly fragment of lens capsule. Yeah, here's a little squiggly fragment of lens capsule. And then we're also seeing part of that probably detached retina and or ciliary body epithelium. And as we go back to the back of the eye, here's the optic nerve and the optic nerve head, and then the detached retina, which once again is quite atrophied. So we're lacking many of the layers that we should have. And then there's also this interesting subretinal membrane in this eye, which is sort of mysterious and not exactly sure what's going on there. Anyway, so this eye has many similar features to the one that we just saw. This is a dog, that was a cat, but very similar features. And so a little bit more wordy diagnoses here, but broad absence of Descemet's membrane and broad anterior synechia with anterior chamber collapse. So in this case, specifically because we didn't necessarily have a whole lot of very specific history from the other eye, I gave two differentials, a congenital abnormality like Peter's anomaly or anterior segment dysgenesis versus a syndrome that we use in Coplow called early life trauma or anterior chamber collapse syndrome. In this case, I think it's sort of academic. We don't know exactly what the answer is. I did think that, as I said, that chunky kind of band keratopathy, that corneal mineral, is something that we see more commonly in abnormal young young animal eyes. And that's something I'd like to pick a clinician's brain about eventually. But in this case, there was evidence that there was lens in this eye, but it was ruptured with extensive resorption, diffuse retinal detachment and atrophy with peripheral tear, and then a subretinal membrane, and then chronic glaucoma. So early life trauma used to be thought of as something that happened very early in the patient's life that led to corneal rupture. We often think it happened behind closed eyelids, so before the eyelids open, which happens usually about 2 weeks of age for dogs and cats. And that is often why we think these globes tend to have not very much inflammation in them, if at all, if any. I personally have started to think that this early life trauma syndrome is probably more likely associated with some sort of congenital abnormality that may be predisposed to corneal rupture. We often get lens extrusion. Sometimes you also get retinal extrusion through the corneal defect, and sometimes we'll actually find embedded lens and or retina in the cornea in these cases, not in this one. So anyway, just sort of an interesting contrasting of two presumably congenitally abnormal eyes from two different species. So that's it. Thanks for your attention. Any questions? Okay, thanks. Yep.
Yes.